Anna, welcome to week 5. You see how quickly this course goes? The coming week, next week, you're going to be getting the reviews for the week 7. So it's in 2 weeks is your exam 2. Exam 2 is a lot on diagnoses and application of information. So it can become quite confusing on your respiratory and of course your cardiac. So these are some really important weeks that this week is a very important week. So on Monday, when I did the other RN class, I found that I just did the PowerPoint and I ran in almost out of time. So that's why I've decided to let you all look at that PowerPoint, that recording, and then I'm going to give you a Kahoot on the concepts you need. But I believe I need to get you where you need to understand at least the cardiac. I think with Med-Surg 1, 2, you have a little bit of understanding about respiratory signs, symptoms, what you'll see. But cardiac is completely different in the pediatric world. So let's go ahead and let's start with just a picture off the PowerPoint that I sent you. And I want to go over anatomy, basic anatomy. That's all I want you to look at here. And then I'm going to go into some little things that you need to know. So of course, it did what I didn't want it to do. Hold on. Sorry. There. Okay, I'm happy my computer's fighting with me, but I'll fight back even harder. Okay, so what do we need to know for cardiac? Cardiology, pediatrics, what is the difference? Well, when you're talking about children, you're not talking about myocardial infarctions. You're not talking about usually things with lipid and cholesterol and clogged veins and all of that stuff. You're talking more about congenital heart defects, and that's the biggest crux of pediatrics, which means congenital, the child is born with it. So in order to know what is not normal in a heart that has a congenital issue, we need to understand the way a normal heart looks like and trace a drop of blood through it. So as I talk about it, I'm going to talk about high pressure areas and low pressure areas, which means if we have holes in between things, remember it goes from the high pressure, pushes it into the low pressure. And I try to make the analogy of a garden hose. If you take a hose and you kink it, it can't go back out the end of the hose. It has to go backwards. And what happens? That hose swells up. If there's holes in it, it's going to squirt, the water through it, right? Or if it's where it's connected on the hose, it's not tight, it's going to squirt there. There has to be some pop-up valve. There has to be somewhere where that water is going to go, or it's going to rip and make a hole, right? So let's just think about that as we go through this picture. So we have a drop of blood. It's gone through the whole body, pumped out by the left side, gone through all of the body, and it comes back by the inferior vena cava or superior vena cava, and it just gets back into the right atrium. So the blood flow is really low in the right atrium because that's the end of a heartbeat. That's the end of where blood goes. It goes through the tricuspid valve, and you got to know where these valves are because some of the questions talk about mitral valve, tricuspid valve, pulmonic valve. You need to know right-sided, left-sided, and how they can be affected. So right atrium, it goes down through the tricuspid valve into the right ventricle. That right ventricle pushes the blood up through the pulmonic valve, through the pulmonic artery into the lungs, where the body gets oxygen in and CO2 out, and it gets ready to go back down through the pulmonary veins into the left atrium. Now, for years, I thought there was one pulmonic vein. Do you know that there's four? So can you imagine how much blood is flowing to that left atrium? That means there's a lot of high pressure in the left atrium. And why do I mention that? Well, at birth, there's that little connection, that patent foraminal valley, which is that little hole that's only there at birth and closes by itself that connects the right atrium and left atrium. So that extra blood flow coming down is pushing blood to the right side. And what does that mean? Well, that means that right side is getting extra blood and has to go recirculate into the lungs. So that's extra pulmonary blood flow because of pressures. All right, so some of the blood is going to go down through that mitral valve, goes into the left ventricle, and that left ventricle is your engine of the heart. And it's going to pump blood out over the aortic arch. It's going to go to the upper extremities in the head by those three little vessels coming off the aortic arch. And then it goes down the aorta and it goes and hits the liver, the kidneys, et cetera, and feeds the body. Now, there's two conditions I want to explain with this picture because I think it really will make sense. What would happen if the aortic arch, right after that, there's a kink in it? So the aorta has a kink. That means blood can't go all the way down, can't go down to the feet and to the organs, decreased blood flow. How would you know that in a brand new baby? Well, wouldn't you check pulses? And we do check pulses on newborns, the dorsalis pedis and the posterior tibial. Those pulses are going to be weak or non-existent, depending on how much blood flow is blocked. That's the first thing you see. Another thing we do on newborn babies is we do 4 extremity blood pressures. So if you have decreased blood flow going down to the lower extremities, your blood pressure is going to be lower. It's less blood flow. Blood pressure is lower. And because you've got those little 3 pop-off valves on the top going to the upper extremities, you're going to see higher blood pressures in the upper extremities. Sometimes coarctation are not diagnosed till later on in life. And the symptoms that you would see is you have all that extra blood flow going to the head. You might have headaches. Also, you have some fragility in the nasal capillaries. You'll have nosebleeds. Those are 2 signs and symptoms of a coarctation or a kink in the aorta that you would see, whether at birth, decreased pulses or no pulses, decreased lower blood pressures, lower extremities, and higher in the upper extremity blood pressures. And in older children, headaches, nosebleeds. So these are some of the signs and symptoms we'll look for. Now, when you were taught OB and you were taught about fetal circulation, you were taught about that there is this little connection between the lungs and the aorta with something called a patent ductus arteriosus. It's only there intrautero. When the baby comes out, the longest it'll stay open is 21 days, and it's usually gone in 3 or 4 days. That this connection stops. You don't need it. It's fetal circulation. But what does it do? It connects the lungs, pulmonic circulation, to the body with the aorta. So it connects the pulmonary artery to the aorta. Now, in some conditions, you cannot get blood flow. Whether it is the upper 2 big main arteries are switched in transposition, you have the lungs going and the body systemic, and they're not meeting. This is one way we can mix blood. We can keep the baby alive until we can turn and switch those 2 main vessels on the top of that heart. What if there is a decreased blood flow going into the lungs? Maybe You don't have a valve between the right atrium and right ventricle. Blood can't go to the right ventricle to go up into the lungs. And it's called tricuspid atresia, A without, there's no opening, it doesn't go through. So this is another one where I need to get oxygen to that infant and I need to give it now. How do I do it? Well, those are two examples, the ones that you'll see a lot, but there's a medication we can give and it's called prostaglandins. It is part of that handout that I sent you. That handout has every term you need for respiratory cardiac. So it's something that you should study. Now, prostaglandins is a slow, continuous IV drip of a medication, and it just holds that duct open. Okay, what happens if that duct doesn't close and we don't need it? You know, a lot of times we see this in premature infants and it stays open. So we need to close it. And there is actually, instead of surgery, there's a pharmacological way, and we give something called indomethacin. And actually, indomethacin is an NSAID. It's just like ibuprofen, but it's intravenously and it closes that duct. It actually what they call it blocks the prostaglandins, which keeps it open, and it will close the duct. And there's many reasons and things that you will look for to see is that duct closing, and that is part of the PowerPoint thing that I gave you. So just remember PDA, indomethacin, prostaglandins, and knowing about kink in the hose. Now I have another question. You've got a kink in the hose. You're seeing no pulses. You're seeing higher blood pressures in the upper, decreased in the lower. Where is that blood going? It can't go down. Well, it goes backwards, doesn't it? Just like a garden hose. It goes into the left ventricle, fills it up, no more room. Goes to the left atrium, fills it up, no more room. It goes back up into the lungs and it causes congestive heart failure. Many children that go home with an undiagnosed coarctation of an aorta end up coming in with congestive heart failure and failure to thrive because they're trying hard, really hard to get that blood around. They're tachypnic, they're tachycardic, they're burning calories, they tire easy, they're not getting nutrition. So these kids are tiny, failure to thrive, and they'll have all those symptoms and they're gonna not be gaining weight on that and they're full of fluid. Okay. So that is one of the concepts, a big concept within the cardiac that you need to think about. And when you're looking at that PowerPoint, you know, take it in mind what I just said. And if it doesn't make sense, again, look at the PowerPoint, listen to the recording. Still don't get it, come to me. We can meet after class, before class. I don't mind. You just let me know. So let's go forward and let's try a Kahoots. Again, I'm going to teach you over the Kahoots. You're not going to be sitting there alone. I'm going to try to get your minds thinking as we go. All right, let's get going. So week 5, respiratory and cardiac. And, you know, they work together. A majority of upper respiratory infections are caused by what? Are these all your bacterias? Are these your viruses? What is it usually? And we know those little toddlers are in their daycares or with other people, and they're just taking everybody's toys and sticking in their mouths, and they're getting everybody else's viruses. Now, you go to the doctor, they say, you tell them, this child's had 104 fevers, and high fevers are very specific to viruses, believe it or not. Those high fevers are usually, and they're full of mucus. We need antibiotics. And the doctor says, no, it's a virus. They will not give you antibiotics until your child's sick for about 3 days. And then they'll say, okay, now we'll put them on. Because if they treated every cough, nose, sniffle, you'd be on antibiotics forever. That poor child would never be without. So they don't try to immediately put you on there. You walk into a 6-year-old room and you find them not breathing and they don't wake up. What are you going to do? I think that's probably one of the scariest things that can happen. You go in just to assess your child and they're laying in bed, they're not moving, they're not breathing. So first thing you do is start chest compressions and you're yelling for help, right? It used to be you give 2 deep breaths first, but they have found that there's enough oxygen in the body that they can go for a while. And they also found the evolution of CPR. In my time, we used to just do the breath because, oh, they need their oxygen, need their oxygen. Well, we found many people were left to die because they didn't want to put their mouths to their lips to do mouth to mouth. And people were dying, children and adults. So they said, no, just start the compressions and get that blood moving around. And hopefully there's enough time for medical emergency people to come, whether you're at home, on the street, and of course in a hospital, you'll have it pretty quick. A multi. What are some signs and symptoms that smaller children may exhibit that have a respiratory infection? Children are really good. When they are sick, they don't feel good. There are certain things that's going to happen. Number one, if they have a fever, they're not going to want to eat. They're not going to want to drink. They don't want to play. And you might see them vomit. Remember, respiratory infection is mucus, right? So they're swallowing mucus, and that can cause the abdominal pain and vomiting. So you see that? What are we going to do? Get that fever down, and then we can get fluids in there. And really, all they need is fluids when they're sick. Fever down, give them those fluids, and then get them to the doctor when you can, of course.
So when they have a fever, you cannot administer fluids.
Hold on. What do you look for when assessing a respiratory function? Now, when they have a fever, absolutely, you can administer it. They're just not going to want it. They don't feel good. No, and they're going to push it away. Once their fever comes down, they're going to drink a lot better for you. They might even eat a little bit, but with the fever up, they don't move. They don't want it. I mean, adults will eat anytime, will drink anytime, but children will not. So when a kid is sick. So when you're assessing lungs, what's going on with them? How fast are they breathing? How deep are they breathing? Is it labored? Is it easy? All of these things we need to look for. Any retractions? What do we see in infants? Nasal flaring, okay? Their noses go in and out. And that might just be the first thing you see. Now, what is scary? Get an infant under 8 years old, their nasal flaring, and all of a sudden at the end of every breath, you hear we call it a grunt, every breath. When you see flaring and grunting, this is an infant who's about to code and go in respiratory arrest. That is scary. So the worst thing you could see, nasal flaring and grunting in your small infants. What would you look for after a child has a tonsillectomy? One of the most common of all things that we do for children, small children, tonsils, adenoidectomies, the ear tubes, all outpatient procedures. So we need to teach these things to our parents. So they should not be in severe pain. They should be able to drink fluids, but of course, slowly, and they like cool liquids most of the time better. But if you have a child tonsillectomy who is not drinking, nothing in their mouth, and you see them swallowing, you know what's happening? They're bleeding. Think about tonsillectomy. They take and cut out the sides of the throat and get the tonsils out. You're left with a cauterized scab. It's like a big scab in the back of their throat. Sometimes through movement, coughing, those sort of things that children do can pop a scab off. And if we see them swallowing, just have them open their mouth. You're not putting anything in there, nothing, but you'll see the blood there. That child most likely needs to go back to the OR and have it cauterized. I have seen a child who was 7 years old go into hypovolemic shock 1 week after their tonsils were taken out. And she was throwing up big, thick clots of blood. So swallowing was the first symptom the parent said she saw. High fever, they shouldn't have, probably an infection at that point. A multi. Nursing care for a child status post tonsillectomy include so we've got that big scab, open area. It's raw, it's red. Make sure that they're medicated for pain. And today we use just Tylenol. Usually that's all they need. We used to send them home with like Hycodan, which is a type of codeine syrup. But we found that we don't need it, and children are actually overdosing on it. So we found it wasn't a good thing to do. So we only give them Tylenol now. Ice bag is really great. It does help. Younger kids don't want it on there, and you'll see it. No, it's too cold. It's too cold. Now, I had my tonsils out at age 21. I wish I knew that chewing gum could have released some of that ear pain and throat pain I was having. It's like pushing your nose and holding it and, pushing air out to pop your ears. Gum does the same thing. It's like that equalizing your ear pressure going underwater. And gum is for your older children, and it works really well. We are not giving spicy foods. It will burn. So softer, easier foods, usually cooler stuff. And if we're giving icy things like popsicles, don't give any red stuff because you don't know then, was it blood? A multi. What would you suspect if a child has a dry, bothersome cough that keeps them awake at night? Now, the chapter goes into croup, pneumonia, upper respiratories, and bronchitis. Asthma. But which one is a dry cough? And this is the one that you're trying to sleep at night and you just can't. It is not asthma. Asthma, it's expiratory wheezing, it's a cough, but it's not just at night, it's all the time. So bronchitis or tracheal bronchitis is the same word. It's just tracheal bronchitis is more specific. It's the trachea and the bronchus that is inflamed that causes you to be awake. This horrible, and you're awake all night long. This is the one that if you were an adult, and children too, what they'll do is they'll give you like a Medrol dose pack. On the children, they'll give prednisolone or Orapred, which is a steroid type thing, and usually a Z-Pack. azithromycin, and they'll get something for cough. Today, cough medicine is limited. They don't have a lot of those narcotic cough medicines around as much because of the dangers of them. But there are some really good choices. And pneumonia, it's not at night, and it's not a cough, and it's not dry. Remember, you've got this gooey, thick, consolidation that the drinking liquids will get it thinner, and you'll be expectorating all of this mucus. It is not dry. A multi. What signs and symptoms would you see in a child with otitis media? So remember, children have little short, narrow, wide open tubes that connect the ears to the throat, and everything's short, distant. So we know if there's least resistance, the mucus is going to go up into the ears. And when you see that, it is clogging up that ear pathway, and it causes pain because you can't pressurize your ears. So it causes a lot of pain. Kids come in holding their ear, or younger infants might even be pounding their head or pounding it on the bed. And then you know where the location is. I mean, if they're hands down their throat hurts. They really can show you in some way where the pain hurts. Again, you might see that little bit of sometimes that ear drum will rupture, and then you'll get all of that purulent fluid coming out. You might see it, or maybe not. And again, when a kid doesn't feel good, they're in pain, they're not going to eat, they're not going to drink. So what would be one of my priority treatments for this child? Treat for pain. Number one. And I always tell parents the ibuprofen, I believe, works better because of the anti-inflammatory in it, right? So always be careful. Otitis media, it hurts. These kids hurt. They don't want hot packs. They don't want any of that. Give them some ibuprofen, and you're going to see a change in them. Many of them run very little or no fever with it. It's the pain, the loss of appetite that you see. And then, of course, the ear drainage, if you will see it, you don't see it a lot, but you can sometimes. The monthly immunization for RSV. Now, we know we give kids a lot of immunizations. The respiratory syncytial virus is a common cold for you or me. Not a big deal. But your infants, to put that extra mucus in their throat, low-grade fevers like 101, right around there, we know that causes a little discomfort. But let's say your kid also has a cardiac condition or was premature as respiratory condition. You put that little mucus in the nose, it's hard enough to suck, swallow, and breathe as an infant. So our job would be to prevent them from getting this common cold, but it's called RSV when they're a young infant. The Synagis, it is a biologic, palivizumab, and it's given once a month from about late fall, early winter into spring. And every month we give it to those immunosuppressed children or those children at risk, like the premature children. And it works really, really good, in addition to all the other immunizations they're getting. All of the following are signs of early respiratory distress in children, except that picture is great. And look at that retraction. The breastbone goes all the way to the back. Very significant in children. You can see it well. Just like adults, tachycardia, restlessness because of hypoxemia, lacking oxygen, diaphoretic, or working so hard. If they are to the point of bradycardia, again, this child is about to code on you. This child, be prepared to do some sort of maybe intubation on the kid. At bradycardia, you are in real trouble. A 4-year-old child's been taking meds for asthma and they're still wheezing. What is important that you need to ask this parent and this child? They're already taking medications. Well, are they taking medications in the correct way? You know, a spacer is great. It's a little mask around the mouth with a little tube, and on the end, you put that meter dose inhaler and you squirt it whatever the dose is, 1 time, 2 times, and you let the child breathe in and out several times. Now, a lot of kids don't like it and they'll cry, but what do? They take deep breaths. So actually, they're getting the medicine deeper into their lungs, which is actually very good. So if they're wheezing, don't assume they're taking medicine correctly. Find out how they're taking it so that we don't, go and upping the level of treatment when we don't have to. An 8-month-old with croup exhibits what signs and symptoms of respiratory distress? Now, croup is that inflammation of the oral pharynx. You have profound inspiratory stridor because it's all inflamed. It's hard to get, air in there. So what are you going to see that makes that worse? Now we're seeing really signs of respiratory distress, the substernal retractions, and we're going to see them getting restless because, again, going into hypoxemia, lack of oxygen. Very good. Signs and symptoms of asthma include all except. Asthma and croup are different. Asthma is the inflammation of the bronchus and in the lungs, and they all swell up, and air gets trapped inside. So you see profound expiratory wheezing, trying to get that air out, but you can get it in. You'll start with like an allergic response, cough, 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 right? You'll start to see those things. Definitely you're going to see wheezing and there are going to be short of breath, but you're going to see prolonged expiratory phase or blowing the air out. It just takes a long time. And if you're listening to that child's chest, you're going to hear a long something, and in the end you hear a squeak on one lobe, if you're lucky, in a child having a true and real asthma attack. It's quite scary to listen to, knowing that they're not moving air at all. Signs and symptoms of congenital heart disease include all except. So remember, congenital heart means that the heart's not formed correctly. And the heart has to make adjustments in order to get the blood around to get oxygen, right? So it's working harder. And when they're working harder, they're burning calories. So they are not eating well, they are tachypnic, they're tachycardic, they're tired real easily, therefore they're not getting the nutrition, and they're going to be weight gain is not going to be appropriate. In fact, it's going to be failure to thrive. What should you not do to children diagnosed with croup and epiglottitis? Now, croup is, as I said, oropharyngeal, gets swollen. If we let that go on and don't treat it with a steroid to stop that inflammation, it becomes epiglottitis. And that's that little thing that covers the trachea when we swallow. So food doesn't go into the lungs, but this now has the trachea covered with a swollen leaf-like structure there, right? You cannot get air in at all. These children look like a chronic elderly COPD, or leaning forward, tripod positioning, trying to find a place and trying to breathe. They're drooling, they're garbled speech. They look like they're in distress, okay? If you go and look in there, what have you done? You have increased the inflammation. There's no reason to look in it when we're seeing this barely getting air in and all those other symptoms. Don't look at it. The epiglottis, what is it? I just told you. It is that leaf-like piece of cartilage that closes that larynx so food don't go down there because it prevents choking. Now, this is swollen. You can't just go in and remove it. There's no way to do it. Even given steroids takes a while for it to work, and you're not breathing. You're not getting oxygen. So as a nurse, what do you need at the bedside in case you need to do a step further to get an airway on this child? Number one, a tracheostomy tray or your intubation tray, because many times you need to do something to get the airway in that. I mean, you're putting up epinephrine aerosols, giving epi sub Q, you're giving IV steroids, you're giving all sorts of albuterol, everything all at once, trying to get that decreased and not swollen, and letting that child sit when and how they want if they're breathing. Very scary time for the parents. Many times you need one nurse taking care of the parent because they are really scared.
So, Professor, so we'll still need to have the intubation kit available, even though the respiratory therapist does the
No, no,
intubation?
in the ER, you're going to
Okay.
be a part of it. Treatment for infectious mononucleosis. Mononucleosis is the kissing disease, right? Mononucleosis is a sore throat, aches and pains, and it's viral. It's the herpes virus. And this is something that we treat as is a kissing disease, but it causes a lot of swelling in the spleen and the liver. And one of the big teaching moments that we give them is, yes, Tylenol and Motrin for pain and fever, lots of liquids, bed rest, no contact sports, and no roughhousing with your brother and sister, because that big spleen, that big liver is like a big balloon ready to pop. And if you hit it wrong, it can explode, and that child could be just bleeding inside and will die. On my recording, you're going to hear about one such little 9-year-old that it happened to, where he went out on an ATV after taught by me and a physician, and he fell off. His belly hit a rock, and this child was dead on arrival into the trauma unit at the hospital where I worked, where I was the primary trauma nurse on, and I had to see him. And it's to this day really bothers me. So mononucleosis, it's viral. Yes, it's treated by rest, but the big thing is protect that abdomen. No contact sports until they're cleared by their physician there. And you were talking about epiglottitis. Now, you're not going to be doing a trach, you're not going to be doing the intubation, but that equipment must be available so that whoever's going to do it can do it right away. Your job is to make sure you have at hand what you need. They're not going to be coming in, oh, I've got the intubation tray. No, respiratory therapists work all over the place. And many ERs, it's the nurse and the physician. They don't have respiratory therapy. Where I worked, they didn't. We did it all ourselves. Although I've gone to other hospitals where the respiratory does do it. So know your procedures. But that was a great question. Thank you for that. A multi. When doing an admission on an infant with a low-grade fever and a loose cough, what information is important? So you're admitting a child to the floor. It's an infant. They've got low-grade fever and a cough. What do you need to know in order to place this child somewhere? You got to put it maybe with another child. I mean, if you're lucky, you have all private rooms, but many hospitals aren't like that. So biggest, most important thing is immunization status. Are they up to date? You would never, possible, you wouldn't do it, if you knew, You're not going to put a child with no immunizations in a child that has them, even if they have the same symptoms, because you don't want to expose them, right? Furthermore, you want to know so you can put a mask on, protect yourself if they're not immunized and they're seeing these symptoms. You know, I've told all of you I have rheumatoid arthritis, really severe, and I'm severely immunosuppressed. I'm also on infusions monthly and then weekly injections of methotrexate. I never ever got influenza or strep throat or any of those contagious diseases because I would always protect myself. Did I always walk around with a mask? No. But if I went into a room, I would ask, are you immunized? And if they said no, mask goes right on me. Okay, of course you use gloves as you're supposed to, universal, but it was because I was thinking enough. And again, placing these children somewhere, most important. And then in nursing care, we want to know how big were the fevers and when was the last medications, especially your antipyretics. When can I give my next acetaminophen or ibuprofen? What is cystic fibrosis? You guys got a really good case study. It did open this week. It's not due till not this Sunday, a week from Sunday, but it's there and it's a great case study to do. Now, case study is inherited, and it's all about the lungs and the digestive system and mucus, and it's all clogged up, and the lungs get full of this thick, I call them petri dishes, because all they do is grow bacteria. And we need to unconsolidate, loosening them up, expectorate. You do physical, that respiratory, PT, all sorts of clapping, exercising, up, walking around, getting those children active to get those lungs moving. And then when we talk about the digestive system, it's the small intestines. There's a problem with the absorption of fat, which means fat soluble vitamins, and fat's your highest of calories, right? So these children are going to be tiny too. Also nutrition, you have to be careful. The thing that you see with these children is they'll see them with the low weight gains, and you'll also see them with stools that are really, they're foamy and they're very foul smelling. What we need to do for the lungs is great, good, intensive respiratory therapy. What we do for the food, the digestive, is to give pancreatase immediately before we eat food, which is snacks or your meals, okay? What is the greatest risk for an infant having a cardiac catheterization? Now, when you suspect a child for a cardiac problem and you go ahead and we do an echocardiogram right after they're admitted to the hospital, you see a problem, be prepared. This child will be going for a cardiac catheterization. We want to find out what's going on there. The biggest thing is all about bleeding. They put catheters in the right groin into the right femoral artery and right femoral vein. And they put big catheters in these huge vessels. And the concern is once those catheters come out, we apply pressure, stop the bleeding, it still can bleed again. One of the first things I always do on any child, any age, coming back from cardiac cath, number one, I'm going to check that dressing. Can you imagine an infant? They could bleed out their whole body in a couple of minutes. Doesn't take long. So making sure we do that. How is cystic fibrosis identified? Sometimes we know a parent has it, so we look for it. But actually, cystic fibrosis at birth, the child will be constipated. It's one of the clues that we'll test them for if a child hasn't had a stool within 2 days after birth. It's one of 3, and this is the first one I'm telling you about. So what were we going to see? Well, we're going to be doing what we call a sweat test, and we're actually looking for sodium. You know, I used to tease the students, go ahead, lick a child with cystic fibrosis and see what they taste like. They're salty. But I'm not going to tell you to lick your child. Have the parent lick it, and they could say, yes, it is salty. These children lose salt. So would this child be on a salt restricted diet? No, they need the salt because they're losing it. And that's how we would see it. And then, of course, treatment would start with that respiratory treatment. And we would start also giving that pancreatase as they're eating so that they can use the nutrition that we're giving. A multi. What is included in the plan of care for a child with cystic fibrosis? So remember, they're losing fat. Fat's gone. So that's one of them. Carbohydrates, fat, and proteins. Fats are gone. So I'm going to tell you, we're going to increase protein. Absolutely. We are going to do that aggressive physical therapy to the chest. We want to keep that lung moving and keep it from getting all clogged up. And again, the pancreatic enzymes. Very good. Good job, guys. What is a drug of choice for the pharmacological closure of a PDA? I mentioned this earlier. There's keep it open or close it. Now, let me tell you about a PDA. When it's open, it's like a machine murmur. It's like a washing machine murmur. Like, you can hear it in the lungs. So we're going to be given this, what we call indomethacin. It's an NSAID. And we give 3 doses of it. We can watch that close by just listening to that murmur. It'll disappear. It'll go away because it closes that PDA. And there's also another thing on the recording which talks about the blood pressure. The diastolic is going to be very low with the PDA open. And as we close that PDA, it's going to go back to normal. Normal blood pressure on a newborn baby is 60/40. You might see 60/18, over 16, 60/16. That's a really wide pulse pressure. That's what we say, what we mean with a wide pulse pressure. And it'll go back to normal, like, yep, it worked. I know the PDA is gone. And again, prostaglandins is to keep it open. What is not a feature of tetralogy of Fallot? I'm going to go into this a little bit more because this is the diagnosis you're going to see on HESIs and NCLEX. I've had many students come back and said, yep, you were right, tetralogy was there. It is what we consider a cyanotic heart disease. It has to do with the pulmonary artery. Somehow it either closes or a piece of tissue covers it, and no blood can go from the right ventricle up into the lungs. And when you don't get blood up into the lungs, you're not getting oxygen. I've actually seen a child, Nolan, I'll never forget him, like Nolan Ryan of the Yankees. That's what the father told me. I said, okay. He, at 5 o'clock in the morning, decided to have a TET spell. He went from O2 sats of 100 down to O2 sats of 10, and it was 2 minutes. He went from pretty pink to black, blue. I mean, it was quite impressive. How do we treat that? Now, there's something I can do. I don't need a doctor to do it. Now, you have compartmental pressures in your abdomen and your lungs. You take the knee and you force it quickly into the chest, on the side, up, this way, anyway, that you get the knees and quickly put them on the chest. And it changes the pressure of those compartments. And usually it will pop open that piece of skin that's covering that pulmonary artery, and it lets the blood flow. And that's how even older children who haven't been repaired yet, for some reason, they feel it happening and you'll see them squat to the floor. It's the same thing. They've put the abdominal pressure, pushed it up into the chest, and again, it stops that TET spell from occurring. So tetralogy is all on the right side of the heart. So Aortic stenosis is left side. So you're going to have on these tetralogy of Fallot, there's always a ventricular septal defect. There is always something wrong with the pulmonary artery, stenosis, some kinking, something going on there. And because when that blood can't get up into that lungs, it's going to stretch out that right ventricle. And that's why we get a hypertrophy. It got stretched. That muscle was stretched. And in time, once it's repaired, it goes back to normal with normal usage. But that is the right ventricular hypertrophy. And then there's one more thing. They say that the aorta sort of pushes over into the right side. It's called an overriding aorta, but it's all right side. So whenever you get a question, tetralogy, think the right side of the heart. What medication would you hold for an infant that is vomiting and the vital signs are 98, pulse 88, and respiratory rate 32? Now we're talking about cardiac children here. What medication lowers a heart rate, right? And we do give this to children, it's digoxin. So how do we give digoxin to an adult? We do the same thing for children. We do an apical pulse for 1 minute. We check their electrolytes, specifically their potassium. We're going to check your digoxin level. And one of the signs and symptoms of digoxin toxicity is nausea and vomiting, but an infant can't tell you. So if you have an infant on digoxin who vomits, you're going to hold the dose. You're going to call a physician, let them know. You're going to do a digoxin level, and depending on that, will you or will you not give that dose of digoxin? So digoxin is the same as adults, but a lot of the younger kids can't tell you what they're feeling. No yellow spots, they can't tell you that. Why would a child with tetralogy of Fallot not gain weight at a normal rate? Another congenital cyanotic heart problem. Remember that body is working hard still. And they're not getting the oxygen they need. And it's going to be decreased energy, their tachypnea, tachycardia, they're burning their calories and they're not eating, and you're going to have poor weight gain. Many of these children are down in the 20 percentile of weight just because of the amount of energy it takes for their heart to work. Not all of them are fixed immediately at birth. Some are a little bit later, depending on the child, okay? Most of them are, but some of them aren't. All are examples of cyanotic heart murmurs except which one? You can take a guess. When we're looking at cyanotic hearts, tetralogy, I've already said we are. I've already said tricuspid atresia. That means A, nothing. It can't go down and up into the pulmonary artery. Now, aortic stenosis, we're still getting blood around, but you know something? ASD is not cyanotic either. Actually, we're going to see extra blood flow going into the pulmonic circulation. So actually, it is aortic stenosis and your ASD, and I'm going to have to change that question. What is the most common cyanotic congenital heart defect? And it's the one you have to know. Most common. We see a lot of them. You know, there are some syndromes that are related to right-sided heart problems, like DeGeorge syndrome, the Q22 deletion syndrome, whatever that means. It means it's something to do with, you know, their chromosomes. Tetralogy of Fallot, most common, and that's why they like to pick on that one for exams, for HESIs, for your NCLEX. Nursing care following a cardiac catheterization. So they've put those big catheters in that right femoral artery and that right femoral vein, and we put that pressure on there. Older children will put a sandbag on there to hold it. One of the things that we do is check the insertion site. Another thing, that right leg must maintain straight, flat. You can't bend it. They will be in bed for 24 hours. And as we're lifting the head of the bed, you're going to go really slowly, okay? They can still eat, they can still drink if they want to. That's not a problem at all. And another thing that we check because of fluids that are given and stress and the way it affects children, we'll be checking a blood glucose level. Sometimes they're high, sometimes they're low, just to see if, again, the low one would be the one we'd be most concerned about. A multi. Nursing education for the cardiac catheterization include all except So we are not going to be bending that extremity, and we are not going to be ambulating. Okay, we don't want anything to pop open the scab where those catheters went in, because they will bleed a lot. I've worked in both pediatric and adult cardiac cath, and I've seen how quickly either or can bleed out. So being very careful, do everything not to cause it to be disrupted and bleed. We're going to do vital signs. We're going to have a pressure dressing. They're going to be in bed for 24 hours, and they still can eat or drink. They don't need an IV if they want to eat and drink. Which information is most important when rheumatic fever is suspected? Now, in pediatrics, there are two conditions that are caused when parents don't completely treat strep throat on a child. It is something that attacks the heart and it attacks muscles, it attacks, joints, and it's all to do with rheumatic fever. And you'll see one in the GI, acute glomerulonephritis, are things that are caused by not treating that strep. Now, the strep causes them to have a rash. It causes nodules and bumps in some joints. It causes, you'll still have the sore throat there, fevers, feeling terrible. It might even get to the point where they have chorea, or they're going to have that really unsteady type of gait. And the worst thing, it can affect heart valves. The mitral valve can be damaged. Now, we will put them on, how do you treat strep throat? Put them on an antibiotic, but it's going to be 4, 6, 8 weeks. It's a long term. And everything can be corrected except that heart valve. That heart valve damage stays damaged, but everything else can be corrected. Signs of shock in children include all the following except. And it doesn't matter, children, adults. Shock is shock. What isn't there? So shock. You're not going to see hypertension. Let me start listing some of the things you see. This is good for Med-Surg 2, Med-Surg 1. This is good for peds. You're going to see elevated heart rate, decreased blood pressure, decreased perfusion, so prolonged capillary refill, altered mental status because of hypoxia, decreased urinary output, confusion, right? These are all the things you see in shock. Hypertension is not shock. Which of the following best describes the pathophysiology of Kawasaki disease? Now, Kawasaki disease is a virus again. And it is one of those viruses, again, that can be scary. And it's basically something that we call multi-system vascularitis. It causes maybe a rupture or a ballooning of a coronary artery. And it causes a little bit of microemboli to be floating around. What would this child look like? They're going to be having fevers. They're going to have a rash all over them. As it progresses, you're going to see peeling or blistering palms of your hands, soles of your feet. You're going to see cracked red lips, strawberry tongue, and the one thing that always I see is those big red glow in the dark eyes. So what do we do for these children? Again, this is a virus. So this is the only time you're going to put your child on aspirin. High-dose aspirin therapy with intravenous immunoglobulins. Why aspirin? Well, twofold. Aspirin helps prevent clots. Microembolus, right, that I told you about, prevents clots. And the other thing is anti-inflammatory, which also helps with prevention of clots. The IVIG just boosts the immune system. Usually it's there for at least 30 days. One of the first tests that we want to do for this child is to do an echocardiogram and look at those coronary arteries and making sure there are no bulging, no ruptures that could possibly be going on there. Actually, my cardiac intensivist, the chief, his son at 3 years old was admitted with Kawasaki disease, and I still see his big red eyes. It was quite impressive. I used to work in the ER then, and I used to like to try to find these children. Very difficult to diagnose. Usually it takes 7-10 days after the initial, I don't feel well. A multi. A manifestation of Kawasaki disease is what? So the erythema marginatum, that's more of fist disease, which is a slap disease thing. It's more of a little tiny little speckled sort of rash they see, but there is a rash, but it is that blistered cracks in the palms and soles of the feet, strawberry tongue and those reddened eyes, and you'll have really good fevers going on here. And we treat the fevers with the aspirin too, right? It works for the fever, and it does also work for that preventing those clots. What is the treatment for Kawasaki disease? Aspirin and IVIG, absolutely. This child is a virus, so antibiotics are not going to work, okay? You don't give antibiotics to a virus. It does nothing. Which of the following is the most common cause of shock in infants and children? You think about children and you say that infants have no immune system. So the biggest thing is infection. The body doesn't know how to handle it. So whenever you're talking about shock, think sepsis, infection, absolutely with children. What are the defects associated with tetralogy of Fallot? What did I tell you about tetralogy? It's all on the right side, right? So when you're choosing this, Think of that right side. PA stenosis, and remember, stenosis is narrowing. There's still blood flow. A as in atresia, there's nothing. Those are two terms. VSD, the aorta, and that right ventricular hypertrophy. Very good. You're listening great. Thank you. A young child with tetralogy of Fallot may soon which position naturally when have a TET spell. This could be a 2-year-old, 18-month-old. Usually by then, we're just about saying, yeah, we need to fix these children. Because we know in infants, what do? We do knee chest, don't we? So these children, all of a sudden, they just squat to the floor and it works. Transposition of the great arteries. Transposition of the great arteries completely puts pulmonic on one side and all of your systemic circulation on another, and they are not meeting. That means this child is not oxygenating at all. The aorta is where the lung should be, and the lungs are where the aorta should be. So that means there's no mix. One of the things that we do for transposition is we put them on prostaglandins because we have to connect those two things, your lungs with the body. So we connect the pulmonary artery to the lungs, to the aorta, and now we've got oxygen going. Actually these children, we figure this out, what's going on. We put them on this slow, continuous drip of prostaglandins, and we can hold surgery off for 7 to 10 days. And now it's not an emergency surgery. It's more of a planned procedure, which is better in so many different ways. Which of the following is not an intervention indicated for transposition of the great arteries? Well, I've already mentioned it's the IV prostaglandins. Now, the surgery itself is called the arterial switch. And the balloons, atrial septostomy, sometimes only that PDA is just not quite enough blood. And you do have that patent foraminal valley between the right atrium and right ventricle, right? At the bedside, they go up in there with a catheter, put a balloon between the right atrium and left atrium. They balloon it up and they pull it. It's like a punch. And it sort of tears open, literally, a bigger hole for blood to go from right to left side to get blood oxygenated to the body. Oral vasodilators will do absolutely nothing. We don't use anything oral on transposition. Almost die. Why is prostaglandins given to a child with transposition of the great arteries? That little picture here, if you look at those little blue little wires in that little box, it's actually a pacemaker. On a little tiny little child like that, we do use them. So this is the biggest concept, prostaglandins. We know it helps with oxygenation, but it also keeps the blood flowing around the body, maintains cardiac output. Prostaglandins is not an antibiotic. It's not an antiviral. Has nothing to do with infections, so it has nothing to do with endocarditis. What is the purpose of giving indomethacin to a neonate with a patent ductus arteriosus? Remember, you have prostaglandins, and then you have indomethacin. When mommy has the baby inside fetal circulation, she produces a hormone called prostaglandins, which keeps this PDA open. And at birth, mommy goes away. So there's no more method of delivery of prostaglandins, right? But sometimes these young children, neonates, infants, say, I'm just going to keep it open for whatever reason. Now you've got to stop whatever that source of prostaglandins is, stop it so it's going to close. So it inhibits the prostaglandins, okay? And that's what that is all about right there. Where is the patent ductus arteriosus? What does it connect? So patent ductus arteriosus connects the lungs to the body, or the pulmonary artery to the aorta, okay? Remember it, it's a big concept. And most of the time when we need to close it, we do it with the indomethacin. At times, we can't close it that way. They'll do surgery and actually put a staple and they'll staple it and close it. But it's like an open surgery, a thoracotomy. This heart defect allows blood to pass from the left ventricle to the right ventricle. What is that called? So you have blood flowing from the right ventricle to the left ventricle. That's a ventricular septal defect. The septum in between the two ventricles, or the ventricular septum, has a hole in it. It's called a VSD, or ventricular septal defect. So if you have a heart defect that allows blood to go from the left atrium to the right atrium, it is what? An ASD, or an atrial septal defect. A multi. What is sign of digitoxicity in infants? What can they tell you? What do they show you? So they will see, that nausea. Sometimes they're retching. You can see that, but vomiting for sure, and heart rate. And they're not going to say, hey, I'm seeing some yellow spots in front of my eyes. They don't have that ability. And again, infection has nothing to do with digoxin. What is congestive heart failure? And it's just the heart, for whatever reason, can't pump well enough. And there's that escape valve that goes up into the lungs, like with coarctation of the aorta. The blood can't go down, so it goes back and it finds that release into the lungs and causes congestive heart failure. And you're going to see that left ventricle is going to be really stretched out after they go and repair the coarctation. They either cut out that piece or they open it, whichever they have to do. But now that left ventricle is really stretched. So it takes a while for it to go back into shape that where it should. And we use that in medications post-operatively. Left-sided congestive heart failure causes what? Left side's not working. What are you going to see? Blood can't flow. Same thing. Very good. You're going to see that all that left stuff, the lungs, the shortness of breath, coughing, fluid. Very good. After a heart transplant, what is the leading reason children die? So when we're talking about heart transplant, it's all about rejection. It's not the infection, it's rejection. These children will be on anti-rejection drugs for their life. When we're talking about the most severe of all of the congenital heart defects called the left ventricular hypertrophy, these children go through many stages of surgery, and sometimes their heart still doesn't work well, and many of them do require a heart transplant. And as long as they get their anti-rejection medicine, these children can do really well. I've got a nice little boy, Thomas, that at age 8 with a hypoplastic heart, he got a new heart, and he got it on Valentine's Day. And today he's still doing really well, and he's 18 now. A multi. Signs and symptoms of rheumatic fever include, well, rheumatic fever is due to a strep throat, right? So we're going to be sick. We're going to have a fever. We're going to have this rash. You're not going to feel good. Might even have a sore throat with it. But you'll see also the polyarthritis, the swelling of the nodules, the subcutaneous nodules, and again, that chorea that I said. Remember, it does cause permanent heart valve damage, and it's the mitral valve. How do we treat it? Long-term antibiotics, up to 1, 2, maybe even 3 months, depending. And the only thing we can't cure is that mitral valve damage. Once it's damaged, it's damaged. A multi. A child's about to have the chest tube removed. What should you do? You know, cardiac surgery, they have 2, 3, 4 chest tubes put in their chest after surgery. And once they stop draining fluid, we take them out. No, I've worked in both the adult and I've worked in the children's open heart surgery. And I've always worked night shift. And I think the night people, the adults, they always first thing before even day shift come in, go around and remove all the chest tubes. So I've talked to a lot of adults about how they feel. Number one, it hurts. It burns. It is what we call an intense burn that it does after, 20, 30 seconds, it goes away and it's okay. But that initial 30 seconds is intense. So any child, let them know and let them know it's going to hurt, but medicate them. Very important, medicate them. And that child, you should have them sitting up, okay? When you have them sitting up, their lungs are expanded, we pull it out, and it doesn't hurt as bad. And of course, you're going to be monitoring their vital signs before and after because we've given some pain medicine. And the kids do okay when you tell them what's going on. You might hold their hand for them. A child just had abdominal surgery and cannot cough well enough to expectorate secretions. What's your priority? I mean, we need to do all that post-op stuff that we do, right? We want to prevent, atelectasis. We want to prevent blood clots. How are we going to get a kid do it that they just can't cough good enough? Well, probably it's they had abdominal surgery. They're in pain. Again, use the pain medicine, and then they'll do everything for you. So medicate them for pain, give them a second. They can reposition, they can get out of bed, they can ambulate, and then you can show them how to use the incentive spirometry, keep those lungs moving, okay? They do have pain, they have a lot of pain. Make sure that we treat it. An infant of 3 months has a fever of 103.6. What would you medicate the infant with? A 3-month-old, how do we take care of fevers? Only acetaminophen. You cannot give ibuprofen till a child is 6 months old. And then after 6 months old, if they had a kid with a febrile syndrome of some sort, You're going to alternate acetaminophen with ibuprofen every 3 hours, one or the other, and that will keep the fever down. Never aspirin, never naproxen on an infant. That's older, more your adult, usually for cramps on an adolescent. And ibuprofen, again, not till after 6 months old. A newborn infant is assessed. The nurse finds very weak lower extremity pulses. What should she assess next? Why do they have weak pulses? This is a newborn. You're assessing a brand new baby. So we're going to do that for extremity blood pressure. Is this a coarctation of the aorta? You know, in my career, I found one. I was working, and I was new even before I went into the cardiac unit. I'm like, I don't feel any pulses here. Something's going on. And it was coarctation, and we found it, and the child did get corrected. So I thought that was pretty cool. I'm a nurse. I figured it out. You know, nurses do a lot. We do a lot for our doctors, don't we? A critically ill child is on complete bed rest. What can you do to prevent complications? Is there any difference between a child or an adult? Critically ill on bed rest, right? Really doesn't matter what the reason why. We've got to do certain things that they don't get into complications. So we're going to keep them breathing with incentive spirometry, deep breathing and coughing. You know, we're going to have them turning every 2 hours, making sure that we prop them. What's pretty neat about children and smaller babies, we can prop them with little baby blankets, and we could use their little toys and stuffed animals to put around them, hold the ET tube, all of these things. Always keep that kid dry. Older children, we could put a chuck there and we could change it or have a bigger diaper if we need to. And elevating the head of bed really doesn't prevent many complications. And many children, because of certain things, aren't allowed to get their head of the bed elevated. But all the other stuff is good. And again, medicating them for pain to be able to turn, to cough, to deep breathe and do that stuff. How can oxygen be delivered that's easiest tolerated and accurately monitored for infants? Now, this is a question from last week, and it is the Oxy Hood. It's that clear plastic. They can suck their fingers or pacifier, and we can give up to 60% oxygen on an Oxy Hood. And we could give it, you know, it's really accurate. Blow by is no, it's not accurate. Nasal cannula, they're like this, always pulling it off. And then they're ripping the tape, and now they're ripping their face and their skin too. And I don't know if any of you ever been intubated. Endotracheal tubes, they're horrible. I've been intubated and it is not tolerated. Even with it in there, knowing I can breathe, I felt like I was gagging and choking. So Oxyhood is great. A multi. What procedure are used to keep the lungs open with a child with cystic fibrosis? Again, we've got all of that thick mucus, that petri dish that's trying to gather bacteria, you know, and grow, you know, germs. And we're going to be deep breathing, exercising, chest PT, and it's not going to be ambulating PRN. It's going to be BID, TID. It's not going to be when they want. They need to be up. They need to be moving. And you know what? Actually, you know, I live in South Florida. One of the best exercises is actually swimming underwater because they have to hold their breath when they go underwater, right? And that's literally exercising their lungs. I'd be happy with that. A multi. Children with cystic fibrosis require pancreatic enzyme with meals. What teaching should be done? This is actually a question off your case study. So you take it immediately before meals or snacks. You can take the capsule and you can open it and sprinkle it on their food because those capsules sometimes are too big for younger kids. If it's the powdered type, make sure you put it on the food, but rinse their mouth. It's just like taking that Symbicort, like with adults, where you have to rinse after using that meter dose inhaler. Same thing. It's going to affect the enamel on their teeth. So make sure they rinse it. And the one thing we always forget, as a kid gets bigger, make sure the dose increases, or they're not going to be getting a proper amount for their size. Some kids grow pretty big in a year, and it's something that should be watched. What is a cardiac defect when there's no valve between the right atrium and the right ventricle? Well, your anatomy, what valve is there? And it's called tricuspid atresia. Remember, A means nothing, no valve. An osis means there is something there. Citrology is a pulmonic valve, and ventricular septal defect has nothing to do with a valve. It's the septum, the wall between the right and the left side of the heart. And last question. When an infant is breathing fast, tires easily, and needs rest periods during feeding, what should you assess? What do you think is going on when you see that? So we're going to look at the breath sounds, aren't we? Because probably they're going into congestive heart failure, and maybe they do need, a dose of furosemide, a Lasix diuretic, just get rid of that fluid. You don't know. So listen to it and see what you are hearing. Okay, good job, guys. A lot of information. Ashley, good job, Ashley. Number 3. Number 2, SpongeBob. Number 1, I got a K. Number 4, JP and Jess. So all of this Kahoot covers all of these concepts you need. Again, I hope that I described it enough as we went through with it. Some students tell me they like it this way because then they're having a question and they can think about it. But go ahead and look at that recording. That can also help you, with that cardiac portion and a little bit more in the respiratory. Remember, you've got those 2 case studies that are open, ready to go, your congenital heart and also your cystic fibrosis, and you have a discussion question due this week. Again, you'll be getting the lineup for who's going to do what reviews when. I've decided mine's going to be on Thursday at 2 p.m. So that will be next week that I'll be doing mine. And of course, you'll get all of them in an announcement. And you'll be getting all the recordings from all the teachers. Does anybody have any questions, comments, concerns? Some great questions came through and I enjoyed that. So thank you.